Start ada. Can you hear me?
Yes, ma'am.
Yeah, shall we start the session?
Is it visible, ma'am?
Yeah, I can see it.
Good morning, everyone. I am Aruna. My topic is acid-base disorders. Normal acid-base homeostasis. The normal arterial pH is 7.35 to 7.45, and the normal H+ concentration is 37 to 45 nanomole per liters. Increase in H+ concentration with decrease in pH causes acidosis, and a decrease in H+ concentration with increase in pH causes alkalosis. Regulation of acid base. It is mainly regulated by buffers, lungs, and kidney. Buffers. Hydrogen ions react with bicarbonates to form carbonic acid under the influence of carbonic anhydrase enzyme, and it dissociates into form carbon dioxide and water. Respiratory regulation. By excreting volatile acids, lungs regulate PaCO2. Normally, CO2 production and excretion are balanced, which maintain CO2 at 40 mmHg, and under excretion of CO2 causes hypercapnia, which results in decrease in pH and cause respiratory acidosis. If overproduction of carbon dioxide causes hypocapnia, which leads to increase in pH and causes respiratory alkalosis. When rate of CO2 production increase, it will stimulate PaCO2 sensitive chemoreceptors at the central medulla with a resultant rise in rate and depth of breathing. This hyperventilation will maintain PaCO2 at normal range. Renal regulation. The role of kidney is to maintain plasma bicarbonate concentration and thereby pH regulation. The kidney regulates bicarbonates by excretion of hydrogen ions by tubular secretion and reabsorption of filtered bicarbonate ions and production of new bicarbonate ions. If excess of bicarbonate ions are lost, it causes metabolic acidosis, and if excess of H+ ions are lost, it causes metabolic alkalosis. Anderson-Hasselbalch equation. Relation between metabolic and respiratory regulation is explained by Anderson-Hasselbalch equation, that is pH is equals to 6.1 plus log bicarbonate by 0.03 into PCO2, where bicarbonates are regulated by kidney and PCO2 are regulated by the lungs. Acid-base disorders. Simple
Aruna,
acid. Yes, ma'am.
your voice is not very clear. Can you just
Acid,
explain?
acid-base disorders. There are two types of acid-base disorders: simple acid-base disorders and mixed acid-base disorders. In simple acid-base disorders, there are four types: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Mixed acid-base disorders. If more than one acid-base disorder is present, it is called mixed acid-base disorder. For example, the presence of metabolic acidosis and metabolic alkalosis in the same person, it is called mixed acid-base disorders. If a pH is normal, there is no abnormality or any mixed acid-base disorder is present. If pH is low, it is asthenia, and low pH with high PCO2 is respiratory acidosis, and low pH with low bicarbonate is metabolic acidosis. If a pH is high, it is alkalemia, and high pH with a low PCO2 is respiratory alkalosis, and high pH with a high HCO3 is metabolic alkalosis. ABG, arterial blood gas. It is a measurement of hydrogen ion concentration, PaO2, PaCO2, and bicarbonate concentration in an arterial blood sample for measuring acid-base status. The normal values of pH is 7.40, PCO2 is 40 mmHg and it lies between 35 to 45 mm of Hg. PO2 is 80 to 104 mm of Hg and bicarbonate is 24 milliequivalent per liters and it lies between 22 to 26 milliequivalent per liters. Approach to ABG. There are three steps of approach. First step is, does the patient have acidosis or alkalosis? And if second step is the acidosis or alkalosis is present, is it a respiratory or metabolic process? And third step, if it is respiratory acidosis or alkalosis, if it is a pure respiratory process or a metabolic component. Step 1, if the patient pH is less than 7.35, it is a acidosis, and if pH is more than 7.45, it is alkalosis. If PCO2 and pH change in the opposite direction, that is, if a PCO2 is increased and pH is decreased, it is a respiratory process. If a PCO2 and pH change in the same direction, that is, if a PCO2 decrease and pH decrease, it is a metabolic process. In a pure respiratory process, for every 10 mm Hg change in PCO2, and the pH should move in the opposite direction by 0.08. For example, if the patient's PCO2 is 30 mm Hg, normal PCO2 is 40 mm Hg, for which there is a decrease in 10 mm of Hg, the pH should increase by 0.08. The normal pH is 7.40. The pH should increase by 0.08, which the pH should be 7.48. Interpretation of result is made easier by blood gas diagrams. Here you can see the blood gas diagrams. The arterial, the x descent is the arterial PaCO2 and the y descent is the pH. The normal value of arterial PaCO2 is 40 mm of Hg and the pH is 7.4. If the pH is increased and the arterial pH is decreased, that is the change in the opposite direction, it is a respiratory. As the pH is increased, it is respiratory alkalosis. If the pH is decreased, if the pH is decreased and the arterial PCO2 is also decreased, as the change in the same direction, it is metabolic acidosis. Steps for interpretation of ABG. First step is to whether it is acidosis or alkalosis by pH. If pH is less than 7.35, it is acidosis, and if it is more than 7.45, it is alkalosis. Second step is whether it is metabolic or respiratory. If the pH and PCO2 are change in the same direction, it is metabolic, and if they change in the opposite direction, it is respiratory. Third step is that if there is adequate compensation is present or not. For compensation for metabolic acidosis is expected PaCO2 is equals to 1.5 into bicarbonate plus 8 plus or minus 2. For metabolic alkalosis, PaCO2 will increase 0.75 millimoles per Hg per millimole per liter increase in HCO3, or PaCO2 is equals to 40 plus 0.7 into HCO3 minus 24. Compensation for respiratory acidosis, for acute respiratory acidosis is bicarbonates will increase 1 millimole per liter per 10 mm of Hg in PaCO2. For chronic respiratory acidosis, HCO3 will increase 4 millimole per liter per 10 mm Hg in PaCO2. Compensation for acute respiratory alkalosis, bicarbonates will decrease 2 millimole per liter per 10 mm Hg and decrease in PaCO2. For chronic respiratory alkalosis, HCO3 will decrease 4 millimole per liter per 10 mm Hg and decrease in PaCO2. And next, calculate the anion gap if metabolic acidosis is present. Uh, then delta gap is calculated if for any mixed acid-base disorders. Delta gap is equals to change in anion gap by change in bicarbonates. If the ratio should be between 1 and 2. If it is equals to 1, therefore there is a pure anion gap acidosis is present. If more than 2, therefore associated metabolic alkalosis is present. If it is less than 1, normal anion gap acidosis is present. Metabolic acidosis. It is characterized by low pH, increased hydrogen ion concentration, and low plasma bicarbonate concentration. Any acid-base imbalance not attributable to CO2 is classified as metabolic. Compensation of metabolic acidosis. It is compensated by respiratory system by increased ventilation. In a metabolic acidosis, the pH is decreased, HCO3 is decreased, PCO2 is decreased, and the compensation is expected PCO2 is equals to 1.5 into serum bicarbonate plus 8 plus or minus 2. Causes of metabolic acidosis. It is divided into two categories depending on anion gap. Anion gap is the charge difference between measured anions and cations. Anion gap is equals to sodium minus chlorine plus bicarbonates. Normal anion gap is 6 to 12 millimole per liters. Causes for the normal anion gap are ingestion or infusion of phenolic acids due to therapeutic infusion or poisoning with ammonium chloride and hydrochloric acid. Gastrointestinal bicarbonate loss due to loss of bicarbonates in diarrhea, small bowel fistula, urinary diversion, pressures. Renal tubular acidosis due to urinary loss of bicarbonates in proximal renal tubular acidosis and impaired tubular acid secretion in distal renal tubular acidosis. Causes for high anionic gap are diabetic ketoacidosis due to accumulation of ketones with hyperglycemia and starvation ketoacidosis and alcoholic ketoacidosis due to accumulation of ketones without hyperglycemia, lactic acidosis and a shock, liver diseases and kidney disease due to accumulation of organic acids. Causes of exogenous acid load, aspirin poisoning due to accumulation of salicylates and methanol poisoning due to accumulation of formic, ethylene glycol poisoning due to accumulation of glycolate and oxalate. Renal tubular acidosis is the most common cause of metabolic acidosis with a normal anion gap. It can be caused by defect in one of three processes. It impaired bicarbonate reabsorption in the proximal tubule, which is the proximal renal tubular acidosis, and impaired acid secretion in the late distal tubule. It is a classical renal tubular acidosis, and impaired sodium reabsorption in the late distal tubule. It is a hyperkalemic distal renal tubular acidosis. Clinical features of metabolic acidosis. Uh, Change in the loss of consciousness, that is confusion, increased drowsiness, decreased BP, headache, hyperkalemia, muscle twitching, and Kussmaul's respiration due to compensatory hyperventilation, nausea, vomiting, and diarrhea. Investigations are arterial blood gas analysis, venous blood sample for sodium, potassium, chlorine, bicarbonate, glucose, lactose, and serum ketones evolution, urine for urine pH and ketones, and anion gap. Treatment. In general severe ischemia, if a pH is less than 7.1, IV administration of 5 equivalents of sodium bicarbonate diluted in 300 ml of sterile water over 30 to 45 minutes during 1 to 2 hours of therapy should be given, and correction of underlying causes are like correction of diarrhea and treatment of shock, etc., and treatment of for lactic acidosis, oxygenation, and IV fluids to promote circulation, and bicarbonate therapy is given if a pH is less than 7.1. In a moderate lactic acidosis, bicarbonate therapy is controversial. Treatment of renal tubular acidosis. Correction of pH and electrolytes with alkali therapy. Alkaline agents like sodium and potassium bicarbonate or sodium citrate are used, and potassium citrate are used if there is hypokalemia is present. Vitamin D and oral calcium supplements also should be given. Treatment for diabetic ketoacidosis. Fluid replacement and insulin therapy should be given. Treatment for alcoholic ketoacidosis, IV administration of saline and glucose should be given. And treatment for salicylate induced acidosis, gastric lavage with isotonic saline and administration of activated charcoal and IV sodium bicarbonate should be given. For treatment for ethylene glycol induced acidosis, saline and osmotic diuresis, thymine and pyridoxine supplements, fomepizole, which is an alcohol dehydrogenase inhibitor, IV should be given. Hemodialysis is indicated when the pH is less than 7.3. Treatment for chronic kidney disease. Oral alkali replacement with amounts of 1 to 1.5 millimole per kg weight per day should be given, and tablet sodium bicarbonate 650 mg or sodium citrate should be given. Example, a 21-year-old patient with 1 week history of vomiting and BP is 90 by 48 mm of Hg and his venous blood sample results are pH is 7.31, PCO2 is 39, bicarbonate is 19, POT is 25, sodium is 108, potassium is 6.2, chlorine is 72, glucose is at 3.3. Solution. Here the pH is 7.31, which is less than normal value. So it is acidosis, and PCO2 is 39 and it is less than a normal value, and pH is also decreased as the pH and PCO2 are decreased in the same direction. It is a metabolic compensation. compensation for metabolic acidosis is expected PCO2 is equals to 1.5 into bicarbonate plus 8 plus or minus 2. Here it is 38.5, which is equals to expected PCO2. Therefore, there is adequate compensation is present. Anion gap. Anion gap is equals to sodium minus chlorine plus bicarbonate. Here anion gap is 17. Normal anion gap is 12. Here anion gap is raised. Therefore, anion gap metabolic acidosis is present. Delta gap. Delta gap is equals to change in anion gap by change in bicarbonate. Here the delta gap is equals to 1. Therefore, a pure high anion gap metabolic acidosis is present.
Aruna,
Yes, ma'am.
it's a very good presentation. And now let us discuss about whatever you have told me, right?
Ma'am.
Go to the example once. Let's go through the slides once. So first we'll start with the example. You can just scroll down to the last slide. Yeah. Here, so why you are doing an ABG?
To assess the acid base disturbance status.
Okay, if you know the acid-base disturbance, so from that what you'll be doing?
pH
No, some patient came to you, 21-year-old male patient came to you with a history of vomitings with hypotension, and you have done an ABG, right? ABG, is it an arterial sample or a venous sample? What do you mean by ABG?
arterial blood gas.
Right.
Arterial blood sample.
Here you mention it as venous blood sample. It should be arterial.
Okay, ma'am.
Okay. So you are doing an ABG. So what is the use of ABG? Why you are doing an ABG to a patient?
To assess acid base disturbance and to know
Hmm.
whether it is a metabolic or respiratory acid base disturbance.
So from that, what will come to the inference? So when you came to know that the patient is having metabolic acidosis, so then what is the next step? Why you are supposed to know that the patient is having
To
metabolic?
treat the patient.
Actually, the main reason why we are doing an ABG is to know the cause. What is the cause for the underlying disorder? Suppose if the
Okay.
patient is having metabolic, you have done an ABG, for example, like this one, and the patient is having metabolic acidosis. So it indicates that, there will be some few causes for metabolic acidosis, right? Like
Yes, ma'am.
DKA or alcohol or something. So when you see the ABG and when you come to a conclusion that it was metabolic acidosis, then you can know the etiology. Then you can diagnose his disease. You can see, by seeing the ABG, you can come to a conclusion. So this could be the diagnosis. Now we have to treat accordingly. So the main use of doing an ABG is to interpret the underlying disease.
Okay, ma'am.
In this case, the patient is having high anion gap metabolic acidosis, right? So what could be the cause of high anion gap metabolic acidosis? There are four causes which you told me.
Diabetic ketoacidosis,
Yes, diabetic ketoacidosis,
lactoacidosis,
lactic acidosis,
renal tubular acidosis,
renal tubular acidosis. It is normal anion gap. It's not high. Diarrhea and RTA are the two causes of normal anion gap metabolic acidosis. For high anion gap,
uh,
it is diabetic ketoacidosis, alcoholic ketoacidosis, lactic ketoacidosis, starvation ketoacidosis, and alcohol or any toxin ingestion. So when you have done an ABG to a patient who is with altered sensorium, it is showing metabolic acidosis. First, you have to check for the pH. Right, pH is in the acidic range. Normal pH is?
7.35 to 7.45.
So here it is 7.3. So it is acid, right? Next you have to see CO2 and bicarb. CO2 is normal. Bicarb is?
Reduced, decreased,
Indicates?
normal 24,
So bicarb is decreased. It indicates
metabolic acidosis.
metabolic component. That too pH is also decreased. So it is metabolic acidosis, right?
Yes, ma'am.
First, whether it's acidosis or alkalosis, you have checked. Next, you came to know it is metabolic acidosis. The third step in ABG. How many steps are there in ABG?
5 steps.
5 steps. Okay. The third step is compensation. You have checked for the compensation and it came to be normal. Right. So it is completely compensated metabolic acidosis. In this case, if suppose the PCO2 is not 39 and if it is 45, then what is your inference?
Respiratory acidosis may be present.
Yes, very good. So along with the metabolic acidosis, patient is having even respiratory acidosis also. So it is a mixed disorder. So it is not only pure metabolic acidosis. So you have to look for the lung. There is some pathology going on in the lung where the lung is not able to exhale the CO2. So there may be patient may having underlying some COPD. So the patient is not exhaling the carbon dioxide outside. So you should look even for the lung pathology, right? Next, you have checked for the anion gap and anion gap is high. If suppose in this case, if the anion gap is normal, then what could be the reasons?
Normal anion gap metabolic acidosis.
Yes, normal anion gap metabolic acidosis. What could be the cause?
Ingestion or ingestion of any inorganic acids, renal tubular acidosis, or
That is high. Normal, remember only two causes. One is diarrhea, other one is RTA, which you told in the previous slide. Okay. So
Okay.
if the patient is having some vomiting history, diarrhea history, so you can attribute that to diarrhea. Okay.
Okay, ma'am.
Next, just before doing ABG, will you do any test to the patient?
Allen's test, ma'am.
Yes, very good. What is Allen's test?
Whether collateral circulation is present or not.
Okay, very nice. So what is the collateral circulation? Which artery? How we are going to do it?
Ulnar,
Yeah, can you hear me?
ma'am.
Do you have any idea about Allen's test?
Oh,
Ulnar artery and radial artery, both of them you have to obliterate. Okay, and then you have to check until the hand is going to become pale. After that, you have to leave for the ulnar artery. You have to
Okay.
check the ulnar artery and you have to check whether the reperfusion of the hand is happening or not.
Okay.
Why you are doing Allen's test?
If any thrombosis or thrombus is present or not.
Yeah, we are poking radial artery, right? If suppose if the patient is having any problem with the ulnar artery, then the patient may go into ischemia of the hand. So to prevent that, first we have to do an Allen's test. First we have to do an Allen's test, and we should be very cautious before poking the radial artery. And if we know that the perfusion everything is fine, then we can go for an ABG.
Okay.
In ABG, what all you are going to look? So after doing an ABG, which syringe you have to use? Hello?
Now, yes, ma'am.
Which syringe you are supposed to use? Do you have any idea?
Oh, ma'am.
Heparinized syringe, okay. We have to take a heparinized syringe. We have to prevent the blood clot, right? So just before drawing an ABG, we have to draw a little bit of heparin into the syringe and we have to throw it out, and then we have to take the blood sample. You're supposed to take an Allen's test. After that, you should take an heparinized syringe and you have to draw the blood and you will keep it in the ABG analyzer and then you'll get a report. So after getting this report, what all parameters you'll see?
pH, PCO2,
Very
bicarbonate,
yes.
partial pressure of O2,
Very good. What is the normal partial pressure of oxygen?
80 to 100.
So here it is 25. So it indicates it is not arterial. Okay.
Decreased.
It is a venous blood sample. So our ABG is wrong. Again, we have to take in one more sample. Or on the other hand, the patient is in severe hypoxia, where his saturation, where his partial pressure of oxygen is 25. So how can we confirm whether it is a venous sample or it is an case of COPD or something where the patient is in severe hypoxia? Do you have any idea? We have to check for the saturation of oxygen. So while taking an ABG, you have to check for the saturation of oxygen and you have to compare the saturations with the partial pressures of oxygen. And if both of them are matching, both the saturation and partial pressure, both of them are low, it indicates there is some problem with the lung. Patient is having hyperventilation. If the saturation is normal, but the partial pressure of oxygen is low, POT is low, it indicates we have taken a blood venous sample. And other one is by seeing the color of the blood sample, you can assess whether it is a venous or an arterial sample. Arterial sample will be cherry red in color.
Okay, ma'am.
One more presenter is there, right?
Yes, ma'am.
Yeah, okay, it's a very good presentation. Okay, let the other presenter come.
Should I share, ma'am?
Yeah, share the screen.
Good morning, everyone. Today, my topic is acid-base disorders. Metabolic alkalosis. In metabolic alkalosis, there is increase in pH, there is increase in plasma bicarbonate ion concentration, and rise in partial pressure of carbon dioxide as a result of compensatory alveolar hypoventilation, often associated with hypokalemia and hypochloremia. Coming to causes, there can be bicarbonate ion overload, like acute alkali administration, milk alkali syndrome, and the other cause is decreased ECF in case of vomiting, gastric aspiration, congenital chloride diarrhea, villus edema. Hello,
Yeah,
ma'am.
I can listen.
Renal origin, like when there is a use of diuretics, post hypercapnic stage, Batter syndrome, Gitelman syndrome. Sometimes there can be ECF expansion along with hypertension and mineralocorticoid excess. There can be high renin or low renin. In high renin states like renal artery stenosis, accelerated hypertension, renin secreting syndrome, estrogen therapy. Low renin like primary aldosteronism, adrenal and enzyme defects, Cushing syndrome. Other causes are Liddle syndrome, cystic fibrosis, ingestion of liquor, etc. During vomiting, there is loss of hydrochloric acid along with the stomach contents. So there is loss of fluid along with sodium and chlorine. This results in increase in secretion of renin and aldosterone. So instead of sodium, the kidneys try to excrete potassium. This results in metabolic alkalosis. Along with metabolic alkalosis, because of increased excretion of potassium, there will be hypokalemia. If there is long-term use of diuretics, they reduce ECF without affecting the total bicarbonate ion content. Diuretics block sodium and chlorine ion transporters. So more sodium is delivered to DCT. So potassium is exchanged with sodium. So there is kaliuresis and hypokalemia. Post-hypercapnia. In post-hypercapnia, because of respiratory acidosis, there is prolonged retention of CO2. This results in increased plasma bicarbonate ion concentration. So, metabolic alkalosis occurs. In this case, chloride supplementation is given. Bartter syndrome. This is an autosomal recessive disorder. Here, the problem lies at thick ascending limb, which results in impaired salt reabsorption. So, there is salt washing, volume depletion, and activation of RAS. This results in metabolic alkalosis, hypokalemia, and normal to low blood pressure. Here the problem is at thick ascending, and there is other syndrome called Gitelman syndrome. This is also autosomal recessive disorder, but the problem is at DCT. Here the sodium and chlorine ion transporter is affected. So in this, there is metabolic alkalosis, hypokalemia, hypocalcemia, and hypomagnesemia. Other syndrome is Liddle syndrome. This is an autosomal dominant disorder. Here, it is characterized by early, frequent, severe hypertension associated with low plasma renin activity, metabolic alkalosis, hypokalemia, no to low levels of aldosterone. Usually, when there is hypovolemia, RAS get activated. So there is release of renin. From that, angiotensin 1 and angiotensin 2 are released. Finally, sodium reabsorption is done. So when there is high RAS, more sodium is reabsorbed, which causes alkalosis. And sometimes without increase in RAS, the aldosterone can be increased if there is any adenoma or carcinoma of adrenal gland or any enzyme defects. Then aldosterone will be increased. This results in indirect absorption of bicarbonate ion in the proximal tubule, and metabolic alkalosis can occur. Other cause is Cushing's syndrome. In here, glucocorticoid is increased by adrenal gland, and metabolic alkalosis can occur. Compensation of metabolic alkalosis is done by respiratory acidosis. For every 1 millimole per liter rise in bicarbonate ion concentration, partial pressure of CO2 increases by 0.7 mm of Hg. The normal values are pH is 7.4. Instead of range for calculation, we'll take single value. And bicarbonate ion concentration is 24. Partial pressure of carbon dioxide is 40. Let's take an example. pH is 7.43. HCO3 minus ion concentration is 32. PCO2 is 40. pH is more than the normal, that is 7.4. So,
What is the normal pH value?
7.4, ma'am.
7.35 to 7.45.
Okay, ma'am.
7.43, it's normal. Okay, you consider it 7.
Okay, ma'am. Just for calculation, we took a 7.4.
We consider 7.5.
Okay, ma'am. Then example is wrong, ma'am.
Okay, it's okay, fine, no problem. Okay, pH is 7.5, bicarb is 32, and PCO2 is 40.
Is 40.
So pH is 5, so it indicates alkalosis. Here
Alkalosis.
bicarb
And
is high, so it is
if-
metabolic component. So it is metabolic alkalosis.
And yes, ma'am. So the increase in HCO3 is 8, 32 minus 24, which is 8.
Okay, continue.
Expected increase of PCO2 is 8 into 0.7, because for every 1 milliequivalent per liter of bicarbonate, the partial pressure of CO2 is increased by 0.7. So into 0.7, which is 5.6. So total increase of CO2 should be 40 plus 5.6, which is 45.6, but PCO2 is 40. So it is uncompensated metabolic alkalosis. Next, coming to the clinical features, because of hypokalemia, there is increased risk of arrhythmias, decreased coronary blood flow, decreased myocardial contractility, and respiratory is hypoventilation, and there are metabolic disturbances, and neurologically there can be seizures. Because of decreased potassium, there can be cramps, myalgia, and muscle weakness. Because of decreased calcium, there can be muscle spasms, perioral tingling, etc. In investigations, urine chlorine levels are calculated. If there is increased renin and increased aldosterone, there can be renin secreting tumors. If the renin is low but aldosterone is high, there can be any adrenal tumors, adrenal adenoma, like that. If both renin and aldosterone are decreased, Cushing syndrome, Liddle syndrome, and any enzyme deficiencies, 24-hour urine cortisol is calculated for assessing Cushing syndrome. Diagnosis: metabolic alkalosis is 2 types: chlorine responsive and chlorine resistant. Chlorine responsive is also called saline responsive, in which When saline is given, the problem decreases, but in chlorine resistance, even when saline is given, the problem doesn't decrease. In chlorine response, the urinary chlorine is less than 10 milliequivalent per liter. The causes are gastric losses, loop diuretics, etc. In chlorine resistant, there are two types: high blood pressure and normal blood pressure. High blood pressure are adrenal adenoma, hyperaldosteronism, Liddle syndrome. In normal blood pressure, Gentleman syndrome, Bartter syndrome. Management. In chlorine responses, saline is given. Along with saline, if to treat hypokalemia, potassium is given. Hydrogen ion blockers, PPIs, are given. If the patient is on diuretics, we should discontinue diuretics. Hemodialysis is done if patient is with marked renal failure. Chloride unresponsive metabolic alkalosis. Here the surgical removal of tumors, aldosterone inhibitors, AC inhibitors are given. If the patient is on steroids, we should discontinue. And potassium is given because only potassium is given because they are unresponsive to saline. Respiratory acidosis. It is a clinical condition in which the pH is less than 7.35 and PCO2 is more than 45 mm of Hg. The causes are inadequate excretion of CO2 with inadequate ventilation because of lung diseases like COPD, atelectasis, or impaired muscles seen in muscular dystrophy, myasthenia gravis, or there can be obstruction of air passages because of tumors, decreased breathing, or the patient is overly sedated with narcotics or drug overdoses. Compensation. To compensate, the CO2 and H plus ion concentration should be decreased and HCO3 is increased. Because of high levels of CO2 in the blood, they stimulate the parts of the brain that in turn stimulates faster and deeper breathing. Kidneys reabsorb bicarbonate ions, they and eliminate H plus in acidic urine. For every, in acute conditions, for every 10 mm of Hg rise of PCO2, the bicarbonate ion rises by 1 milliequivalent per liter. In chronic conditions, for every 10 mm of Hg rise in PCO2, HCO3 rises by 4 milliequivalent. For example, if the pH is 7.25, PCO2 is 55 and HCO3 minus is 30. PCO2 is less than the normal, so it is acidic. And sorry, pH is less than the normal, so acidic. And PCO2 is more than the normal, so it is respiratory acidosis. So the increase in PCO2 is 55 minus 40, which is 15. For every 10 mm of Hg rise in PCO2, HCO3 rises by 1. So for 15, it should be increased by 1.5. So expected HCO3 is 25.5, which is, but the actual one is 30, which is more than the expected one. So there is both respiratory acidosis along with metabolic alkalosis. The features are, because of increased PCO2, there can be cyanosis, and because of hypoventilation, there is hypoxia, headache, hyperkalemia, drowsiness, disorientation, muscle weakness. Treatment is by improving his ventilation, and if PCO2 is more than 50, then mechanical ventilation is given. Adequate hydration and oxygen supplementation is given. Respiratory alkalosis, here the arterial pH is more than 7.5, 7.45 and PCO2 is less than 35 mm Hg. The causes are hypoventilation, which excessive CO2. The causes are extreme anxiety, hypoxia, inappropriate ventilator setting, CNS trauma, early phase of salicylate intoxication. To compensate, there is increase in CO2 and H plus and decrease in bicarbonate ion concentration. So kidneys conserve H plus ions and eliminate HCO3 minus. In acute conditions for 10 mmHg fall in PCO2, HCO3 decreases by 2 milliequivalent per liter. In chronic conditions for every 10 mmHg fall in PCO2, HCO3 decreases by 4 milliequivalent per liter. Example, if pH is 7.52, HCO3 is 22 milliequivalent per liter, PCO2 is 30 mm of Hg. Here pH is more than normal, so that is alkalosis, and PCO2 is less than normal, so respiratory alkalosis. Fall in PCO2 is 40 minus 30, which is 10. So for 10 mmHg fall, the HCO3 minus ion should be decreased by 2 milliequivalent. So 24 minus 22 is 22. So it is compensated respiratory alkalosis. The clinical features are seizures, hyperventilation, tachycardia, hypokalemia, numbness, tingling, lethargy, confusion. Treatment is first we should treat the underlying cause, and the patient is instructed to breathe slowly to allow more carbon dioxide to accumulate, or to breathe in closed systems such as a paper bag. Sedative may be required to relieve hyperventilation in very anxious patients. Adjustment of ventilator settings. Thank you, ma'am.
Okay. It's a nice presentation. Let us
Thank you,
discuss
ma'am.
on the last
Okay, ma'am.
regarding respiratory alkalosis. Can you go to the slide which is showing symptoms of respiratory alkalosis? Yes. So why the patient is having seizures?
Because of decreased because, of decreased PCO2.
Decreased
Well, that,
anything
yes,
else?
ma'am. And hypokalemia.
Hypokalemia will not have seizures. Hypocalcemia. Patients with respiratory alkalosis, they will have hypocalcemia.
Calcium. Okay.
What is the cause of hypocalcemia here? Do you have any idea?
No, ma'am.
Because of the increased pH, the calcium will be more bound to the albumin, so that the ionized or free calcium will be decreased. So because of the free active ionized, decrease in free active ionized calcium, the patient will have hypocalcemia, and patient will have symptoms of hypocalcemia. What are the symptoms of hypocalcemia?
Uh, the,
Mentioned in this slide, you see carefully. Tingling,
seizures,
yeah,
tingling, numbness.
yeah, perioral tingling and numbness they'll be having. They'll have seizures,
Yes,
and there
ma'am.
will be lethargy, confusion. There will be
Yes, ma'am.
ECG changes. What are the ECG changes of hypocalcemia? Any idea? ECG changes of hypocalcemia and hypokalemia. Hypocalcemia, hypokalemia, both of them will cause QT prolongation.
Okay.
And any more ECG changes of hypokalemia?
Inversion of P wave,
Inversion of P wave. It's very,
flattening or inversion
what is
of
the
P
early
wave.
presentation?
Hmm.
Hypokalemia. U waves.
ST depression.
Yeah, ST depressions. U wave. Initially, you'll have U waves,
P wave.
ST
Yes,
depression,
ma'am.
and then loss of P. Can you go to the previous slides? First, it's metabolic alkalosis. We are not only learning about the acid-base disorders, we are even learning about how to analyze an acid-base balance. So after doing an ABG, when you come to a diagnosis of any acid-base disorder like any metabolic alkalosis or metabolic acidosis, next you have to look for the underlying etiology. What is causing this metabolic acidosis? What is causing this metabolic alkalosis? So then you will come to a conclusion, and then you have to treat both the underlying disorder as well as this acid-base abnormality. Now in metabolic alkalosis, you go to the causes. So you can just simplify these causes into two categories. In one category where the effective extracellular fluid is decreased, and in the other one where the ECF is normal or increased. So the condition where ECF is decreased includes GI causes or renal causes like using of diuretics. Well, you come to the other category where the ECF is normal or increased, it includes the ROS system. So it can be any causes of ROS. It can be because of high renin or else high aldosterone, anything. Finally, the aldosterone should be high. The aldosterone is increased, which causes sodium absorption and potassium excretion and leading to hypokalemia and metabolic alkalosis. So when you treat a patient with if you some patient came to you, you have done an ABG and it is showing metabolic alkalosis. So what is your next step? What you will do next?
Metabolic alcohol.
Some patient came.
To check whether it is chlorine responsive or chlorine resistant.
Okay, clinically, how can you assess that? Whether it is chlorine responsive or chlorine not responsive?
Depending upon the cause, like
One is depending upon the cause, that is depending upon the history, whatever he says. If he says he is on diuretics, or he is on loop diuretics, or he is having any history of vomitings. So with that history, you will get one clue. And the other one is on examination of the patient. What you look for the patient of metabolic alkalosis? Receive expansion, receive contraction. There are two terms here, right?
yes, ma'am.
It will look like volume depleted. You have signs of dehydration. You can access it could be because of vomiting. Patient is having volume depletion, so it could be chloride responsive, and you can give one normal saline and you can see whether the patient is improving or not. You give normal saline around 1 liter, and then after that again you repeat an ABG, and again you'll see whether it is getting corrected or not. If it is not getting corrected, and if the patient is not having any signs of dehydration and his blood pressure is high, if the blood pressure is high, it indicates
Adrenal adenoma
it
or
could be possible
renin circulating tumor.
aldosterone levels are high, right?
High.
You have to suspect.
Yes, ma'am.
The other factor is where the ROS is involved, and you have to search for the cause, whether is there any tumor or something like that. And here one more thing, if the patient is not responding with the fluid, then what else you can add?
Potassium. No, it's not
Potassium,
potassium.
you can give potassium because patient will have hypokalemia. You can correct the potassium by supplementing potassium. For alkalosis, so do you have any drug? Metabolic alkalosis, right? So the alkali, the bicarb is increased. So do you have something to decrease the bicarbonate levels? Can you give something to the patient? So you can give estrazolamide. Estrazolamide is?
HCl.
Estrazolamide is? What is the mechanism of action? Where it's going to act? Somebody is answering, I guess I can't hear. Estrazolamide is carbonic anhydrase inhibitor. So it helps in the excretion of bicarbonate so that the alkalosis will come down. Am I clear?
Yes, ma'am.
Okay, next. Go to the next slide. You just next. You just go to the previous one, that photo one. There is Liddle syndrome in this photo. Where it's going to act? Where is Liddle's? You mentioned Barter, Gentleman. Where is Liddle? Liddle, where it's yeah.
Here, ma'am.
It's going to increase the activity of INAC channel. Okay, so there will be more amount of sodium reabsorption. And there is a mnemonic for this. If you want, you can remember. It's like let's go back. L for Liddles, G for Gentleman, B for Barters, and we are labeling it from the collecting duct to the loop of Henle. Let's go back. It's Liddles, Gentleman's, Barters. You will not forget it. Next Next slide.
Next, ma'am.
Yeah. Next. I'll just stop you if whenever necessary. Metabolic calculus, can you go to metabolic calculus treatment slide? Yeah, the table, chloride, responsive chloride. How this liquorize is going to cause metabolic alkalosis? So one we thought is the ECF volume loss or the raw system activity. So ECF comes under the chloride responsive ECF loss. With in chloride resistant, this raw system is going to come. So everything is towards the ROS. And how this Cushing syndrome and licorice will cause metabolic alkalosis. What happens in Cushing syndrome? Any idea? Which hormone is going to be overproduced? Which hormone is in? Yeah, yeah. Which one? Cortisol, right? Cortisol will also have, yes, very good. Someone answered me. Cortisol, some message I got, right? So cortisol will even have a mineralocorticoid action. It is a glucocorticoid, right? So it will have even a mineralocorticoid action. It's like aldosterone. So it will absorb sodium and it will excrete potassium. So there will be hypokalemia. Hello? Can you listen me? Can you hear me? Hello? 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 There's something wrong. Okay, anyway, it's a good presentation. Both of you presented very well. If you can hear me. హలో ఇది అయిపోయినట్టుంది ఒకసారి చూస్తారా ఓకే ఉన్నారా మౌలి దగ్గర ఉన్నారా Are you there? Okay, no problem. So only one thing which you would like to tell you that even the glucocorticoids will have a mineralocorticoid action. When the glucocorticoid levels are raised, when it's more than normal, they'll go and sit with the aldosterone receptors and it can act as a mineralocorticoid and it helps in sodium absorption, potassium excretion, and the patient can go to hypokalemia and metabolic alkalosis. That's it. And the rest all, it is fine. So both of you have presented well. I just want to give you a bit of clinical orientation to this theory topic. That's it. So, okay, I guess our time also came to an end. Okay then, have a nice day.